My name is Emma and I'm a pharmacist with the HSE, but in my free time I am also an educator with the National Frailty Education Programme, and I'm here today to give you a very, very brief overview of the concept of the fundamentals of frailty, appropriate and inappropriate polypharmacy and medication. On my last slide as well, so you can take a note of that as well. So slide number 3, please, Colin. So just looking first of all today at polypharmacy and the polypharmacy module that I deliver in the National Frailty Education Programme. So Grania mentioned earlier that the World Health Organization has cited addressing polypharmacy as a major priority to reduce severe avoidable medication-related harm. And I suppose the most cited numerical definition of polypharmacy are those patients taking 5 or more regular medications daily. But like age, that's only a number, and we have all encountered patients doing really well on maybe 15 medicines and others who are unhappy taking just 3. What is important when it comes to polypharmacy, that each medication is appropriate for the individual at that time point in their life. Tilda tells us that 50% of people aged over 75 years take 5 or more regular medicines daily. And the Tilda Polypharmacy Report recommends regular medication review to ensure each of their medicines are appropriate for them. Slide 4, please, Colin. So when we look at medicines, we know that they save lives, and they're really, really important. So here we look to the concept of appropriate polypharmacy. So in order to define appropriate polypharmacy, that all drugs are prescribed for the purpose of achieving specific, achievable therapeutic objectives, and that these have been agreed with the individual, that the risk of adverse drug reactions have been minimized, and that the person is actually motivated and able to comply with the medicine regime. So an example of this would be somebody who suffers a heart attack and are discharged on 6 regular medicines. So they'd have their dual antiplatelet therapy, their PPI to protect their tummy, their high-dose statin, their ACE inhibitor, and their beta blocker. If the person is willing and able to take those 6 medicines, then we have appropriate polypharmacy. Slide 5. So now looking at inappropriate polypharmacy. This is where the potential harms of one medication actually outweigh any potential benefit. Firstly, there might be no good reason for the person to be actually taking the medicine, and the indication might be expired. So here we might see somebody who started on an antihistamine during the summer months and it ends up getting continued long term, or somebody prescribed dual antiplatelet therapy for 1 year, but it gets continued long term. Secondly, the medication might not actually be working for the person. So is our pain relief actually providing pain relief to our patient? Is the inhaler actually relieving the breathlessness? Thirdly, the medication might actually be causing unacceptable adverse drug reactions for our patient. And lastly, the medication taking regime might actually become burdensome, and that is particularly seen whenever frailty progresses. Slide 6, please, Colin. So why does polypharmacy occur? Our patients are living longer, thankfully, and they're seeing more and more specialists. But a patient is actually considered multimorbid if they're living with 2 or more long-term conditions or symptom complexes. One of these might actually be frailty. So only in 2017 did NICE actually release multimorbidity guidance, which gives healthcare professionals permission to stop stringently adhering to all single disease guidance that came before it. So that is one of the leading contributors to polypharmacy. Slide 7, Colin. Next, prescribing cascades, and these are a real cause of polypharmacy for our patients. So at this time of year, we might have one of our frail elderly patients. hurts their back when they're putting up their Christmas tree, for example, and they go to their GP and they're prescribed an NSAID. It relieves the pain, but they're in for the regular checkup and it's identified that they now have developed hypertension. So the patient is given a calcium channel blocker. A few weeks later, the patient returns with some ankle swelling, for which they're given a thiazide diuretic. This in turn causes gout, for which the person is prescribed allopurinol, and so on and so on. And so we see that a prescribing cascade has occurred and our patient is now living with unnecessary polypharmacy. Recognizing prescribing cascades is essential for older people living with frailty, because what is actually a side effect of a medication may easily be attributed to the aging process, disease progression, or the development of a new condition. Slide 8, please. The links between frailty and polypharmacy are really strong, and the paradox is that the risk of frailty grows with the number of medications, but the number of medications prescribed grows as frailty progresses. So it's a bit of a catch-22. People taking 10 or more medicines are twice as likely to develop frailty. And those living with frailty are twice as likely to be prescribed potentially inappropriate medication. And also, those living with frailty are 3 times as likely to be admitted to hospital. Slide 9. So, what are these vulnerabilities associated with aging? Why are our older patients ending up in hospital as a result of adverse drug reactions, and a younger, more robust person can take a medicine without causing any ill effects? Well, this comes down to concepts such as pharmacokinetics. So this is what the body actually does to the drug. And as we age, this concept of pharmacokinetics changes. So when we take a drug, it is absorbed from our gastrointestinal tract. And as we age, there is an increase in our gastric pH. So this would actually affect the absorption of medicines such as calcium carbonate. After absorption, the medicine is distributed throughout our body, and as we age, we have an increased proportion of body fat. So this means medicines like fat-soluble medicines such as benzodiazepines will have a longer duration of action for our frail older people. After distribution, our drug is metabolized, so it may be metabolized by our liver, which we can see a decline in liver metabolism as we age. So medicines such as amitriptyline, warfarin, and opiates might end up causing more ill effects for our older patients. And lastly, after metabolism, our medicine is excreted, for example, through the kidneys. There may be a reduction in kidney function, which would affect medicines such as digoxin or non-steroidal anti-inflammatories. Slide 10. So then we look at the pharmacodynamic changes. So this is what the drug actually does to our body. So as we age, there is altered homeostasis. So this causes the reflex that maintains our blood pressure on standing to become slower. So this means that older people are therefore more susceptible to antihypertensive induced postural drops, and that will increase their risk of falls. Also, changes in the responsiveness of our target organs, for example, medicines that target the central nervous system, tend to cause more drowsiness and confusion in older people. They may actually trigger a fall or a delirium for the older person. So slide 11. So how do we overcome this concept of inappropriate polypharmacy and ensure our person who might be taking 20 medicines are actually taking medicines that are appropriate for them at this point in time? And the answer to this is a medication review. So this is a structured, critical examination of a person's medicines with the objective of reaching an agreement with the person about treatment, optimizing the impact of medicines, minimizing the number of medication-related problems, and reducing waste. So that's a lot to do in a busy clinic. So one way that we approach this is by adapting the Scottish principle to appropriate polypharmacy by utilizing the 7 steps to a medication review. This is a person-centered, structured way of looking at a list of medicines. So step 1 is what matters to the patient. So here we might be looking at symptom control, preventing disease preventing disease progression. But it might be something as simple as I want to be able to mind my grandchildren again with confidence, or I want to be able to drive again. Step 2 looks at identifying essential drug therapy. So these are medicines that should not be stopped without the input from a specialist. So here we might look to medicines that have a replacement function, such as altroxin or hydrocortisone, but also medicines used for things like heart failure or Parkinson's disease. And we look to make sure that those medicines are optimized in step 2. So step 3 looks at any unnecessary drug therapy. So here we might look for expired indications or maybe high doses. So patients on unnecessarily high doses of a proton pump inhibitor, for example. Or we might look at medicines that are going to have maybe a 10-year benefit for our patient who might be at the end stage of their life. So step 4 looks at, are we actually achieving the therapeutic objectives? So is our pain analgesia actually providing pain relief? And if it's not, then why isn't it? Are we reaching our biochemical and clinical targets? Are the bloods actually reflecting the doses that are being prescribed? And here we'll always look to, is the person actually taking the medicine? Are they able to adhere to the medication regime as well? So moving along then to slide 13, Colin. So step 5 then looking at safety risks. So here we might be looking at high risk drug monitoring, drug interaction, drug disease interaction. We'd be looking at prescribing cascades. And then step 6 starts to look at any unnecessary cost. And this has been updated recently to look at sustainability of prescribing as well. So we want to eliminate any unnecessary waste as well. And then step 7 looks at our person-centeredness. So here we make sure that we may simplify the regime. We might look to providing a blister pack. Does the person need a carer to help with the administration of the medicines? And we agree and communicate a plan with the patient. So step 14 is, slide 14, is looking at deprescribing. So deprescribing is the planned and supervised process of dose reduction or stopping of a medication that might be causing harm or no longer be of benefit. So the process of deprescribing might actually be more complex and challenging than the initiation of a drug therapy. We're getting more and more people and professionals with prescribing rights, which is wonderful for lots and lots of our patients. But we need to start looking at, do we need to deprescribe a medicine in order to safely prescribe another? There's a lot of evidence being generated in terms of deprescribing, and this can be looked at whenever if you do complete the full in-person or HSE land polypharmacy module as well. Moving along then to, just in terms of deprescribing, it's really important that even if we're following guidance, that we tailor any deprescribing guidelines to our patient, and that we should only make recommendations within the limits of our professional competency. Looking then at slide 15 and looking at medicines that are associated with falls, and in the National Frailty Education Programme, there's a whole module dedicated to falls, but there are a lot of medicines that can increase the risk of falls for our older, frail adults. And this list is certainly not exhaustive. And here we might look at medicines that might be reducing the blood pressure too effectively or reducing the blood sugar too low, increasing the risk of falls. But really importantly, we should look whenever conducting a polypharmacy medicines review, is to looking at the cumulative effects that medicines can actually cause on the falls risks for our patients as well. Slide 16 is looking at medications that are associated with delirium for our frail older adults. And again, there is an entire module dedicated to delirium in the National Frailty Education Programme. And here, of course, the M in the Pinch Me acronym for delirium does stand for medications. But I want to point out that if you are working with an adult who has experienced a delirium, medications can actually impact on many many of the other components of the Pinch Me acronym. So looking at pain, is it a side effect of our analgesia, or is the pain actually even being controlled with what we're providing? Looking to infection, and Aisling talked really well about the appropriate use of antibiotics. And then we might see that we have our older, frail adult living with taking trimethoprim, for example, for maybe 4 years, but they're actually experiencing repeated urinary tract infections. So that would cause for a review of the trimethoprim in that case. The N then, looking to nutrition, is the medication actually causing nausea, vomiting, or diarrhea that's actually affecting the nutrition of our patient, or is it actually causing constipation for our patient, such as an opiate, for example? And then hydration, is our patient actually dehydrated as a result of diuretic therapy? Moving along then to slide 17, please. Looking then to the gold standard whenever it comes to frailty and delivering care to our older adults living with frailty. And that states that regular medication review is recommended for all older people living with frailty and polypharmacy. My final slide then is slide 18, and that is just to let you know once again about the National Frailty Education Programme run in the CNME in Sligo with a fantastic team, and that is all of the topics that are covered, and it's also covered on HSE land as well. Thank you.
With that in mind, I'm going to move on to our final talk, which is by Patricia Murray, and it's auditing